Okay, Jimmy is out of town, or actually he's not. He's doing a funeral this morning. He was going to be out of town, but he's doing a funeral, and Carl is on vacation, and Barbara is here with us. So I think we've present and accounted for. Why don't we seek some guidance here with a prayer, and then we'll give a pledge of allegiance. You'll join me and stand. Dear Heavenly Father, we thank you for the fact that it's Friday and it's a beautiful day. We are grateful here, Lord, to be having a meeting to plan for our 2020 county health insurance. This is a difficult task to try to predict the future and what's best for the county. We just pray for supernatural direction as we decide on small details and large details. Just help us to do what is best for all concerned, including our employees, their families, the taxpayers. Just show us what is the best route to take in each one of these decisions. We turn this meeting over to you in Christ's name. Amen. Amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. All right, today is the second day of August 2019, and it's just after 10 o'clock, and we're gathered today with the court and with members of our auditor's department, as well as Chris Kaplinger from UMR and Tony Melton from Higginbotham. And we are here to discuss a few things. Just in my notes, we're going to discuss whether there are any plan changes that we should make to the current plan in the way of rate changes or requirements by our employees, or any of the finer points like emergency room visits. There's lots and lots of details on this plan, and we want to see if there's anything that we can do this upcoming year that will produce better benefits for us, or better benefits to the county as far as cost, as well as better benefits to the employees, and try to find a good mix between those two. We've got some notes here that Sharon has made for me that she wants us to discuss, and I agree each of these items need to be discussed, because we want to do things in a way that are not only beneficial and cost efficient, but we want to make sure that we're not overloading our auditor's department with things that we don't intend to. And we will discuss anything else that comes up here, but let's begin by kind of going over what the current plan basic rates are. I think I have a pretty good feel from the commissioners as to what they're thinking for this upcoming year, and I'm kind of thinking that you don't want to rock the boat this year with a bunch of major changes and rate changes, but I don't want to assume anything, and I want to give each of you an opportunity to express your opinions. But I've given you our current employee benefits booklet, and you can see there, if you'll look on page 4, I want you to be familiar with what some of the basic components of our plan are. And let's start there and look at what's in effect here in 2019 in both in-network and out-of-network claims. You can see that we're currently operating with a $1,250 deductible. That is a $3,750 family deductible, and that means, I guess, if somebody has a wife and 5 kids, and once they exceed $3,750, even though one may not have had any of his deductible used, the first dollar that next person spends would be covered, because as a family they have exceeded $3,750. And the annual maximum out of pocket for an individual, $6,550, meaning that includes their co-pays and their deductibles. And so once they have paid medical expenses of $6,550 or more, regardless of how serious things get for them, Every dollar past that is paid for, assuming that it's in network and meets all of the other requirements. Looking at the family, under that same scenario, an annual family out-of-pocket maximum $13,100. Our co-insurance right now is set up on 70%. We've come from past years of being, I think, at 90-10, and then we went to 80-20. Now we're at 70-30, and basically that's just how we share each dollar spent between our insurance coverage and our personal expenditures. We have a $30 office copay. That may have been $25 in the not too distant past. We have $0 copay for somebody that uses Teledoc. We encourage the use of Teledoc as a way to defray office visits possibly and provide immediate weekend or night help to somebody that might have a relatively simple medical need. We have urgent care cost of $75. Will you elaborate again once more on this? Because even I lose track of what are we defining as urgent care and emergency care and differentiating between the two and why it's more expensive than our $30 office visit.
Well, a lot of times you will find an urgent care center that's open in the evenings and on the weekends. When Healthcare Express opened up here, I thought they were going to be filing claims as urgent care, but apparently they are not. They are filing as office visits. So if you're doing it with that way, you're actually in a better scenario because it's a $30 copay instead of $75. And they told me the reason why is just because they didn't think that they had enough utilization to file as an urgent care. Do you have any information about that? But you still have urgent care facilities at the Titus Regional Center, whatever that's called, the Family Care Center. They will file as urgent care. It just gives you access. But if you left Mount Pleasant and you went to, say, Texarkana or Longview, there are other urgent cares that are available. And the reason it's $75, I'm assuming, is just because it was, can you shed some light on that?
They do, like Tony said in the beginning, they're open extended hours, nights and weekends, and they also have the ability to perform more services than you would just at your doctor's office. So they can set some fractures, they can do some stitches, and take x-rays, and do some lab work, and things like that, so that not necessarily can be or can be performed at every doctor's office.
Does the urgent care expenses to the county tend to be higher than the local doctor's office?
Let me look at our past report. So your urgent care, your average cost is $149 a visit, and your average cost on an office visit was $63. And then your average cost on an ER was $2,249.
Okay. So the fact that our health, what is it? What's ours here in town that's filing as a
Healthcare Express.
Healthcare Express. Even though for our employees, hey, I can go out there, I'll just quit going to my local doctor and I'll just start going out there all the time. I may get away with the $30 bill, but it's dumping double that cost on
from Titus County people, but I have another group here in town that asked me why are they charging me the office copay, because that group actually has a lower urgent care copay than an office visit copay. So yeah, so they were kind of ticked at that. But in your situation, it would be a better scenario if that is the way they're going to continue to file. That's not the way all Healthcare Expresses work. For example, the one in Texarkana, the big, huge one, if anybody goes down Richmond Road, it's really big on the left. I've had people, actually Jessica, my account manager, I think we told you this example, that's where she went for an MRI, because it was only like $250 to have an MRI compared to $900 if she would gone to Titus Regional. So that one there is definitely an urgent care and can do a lot of different things. So I think the way Healthcare Express works is that different locations are contracted differently with the insurance companies.
Maybe I didn't ask my question right. If I go out here and I give them $30 at Healthcare Express for an office visit, how much are they going to charge the county? Are they going to look for any more money than $30? I would assume so.
Well, they've got an allowable amount,
Right.
just like any other doctor would.
Right.
So it's going to be whatever.
I wouldn't be able to tell you that off the top of my head unless I looked at a
claim.
specific claim.
Okay.
And this average I gave you of $149, that takes into account using any urgent care facilities that your members may have gone to.
So that 63 versus 149 doesn't necessarily mean that they're more expensive in their cost to the county. It just means that for people that went to Healthcare Express, they got more stuff done there than they might have gotten.
Absolutely.
Maybe because they needed it. Maybe it was truly an urgent situation.
Yes. And I also think a lot of it is that they're open later in the week, in the nights, where your doctor's offices tend to be, 8 to 5. They may be open a little earlier in the morning. They're walk-in.
And they're walk-in. That's
You
what
don't
I was
have-
fixing to say. Yeah, you just
don't have to
go.
make an appointment.
Yeah.
You can just walk in where you have to call your primary doc. If you do not have a primary doctor, then calling and trying to get an appointment with a primary doctor during certain times of the year is more difficult for a patient.
Okay.
It's non-established is what it's called.
Okay. We've made some many tweaks to these over the last few years in these rates and in these mixes between urgent care and emergency care and non-true emergencies. Is there anything that we can do here that's going to significantly impact our overall plan performance? We know that the biggies are the 5 and 6 employees each year that go well above the typical amount, and we exceed our stop loss. But as far as wanting to continue to find chinks that we can fix and produce better benefits, are any of these an opportunity today to talk about?
I think, and when we were here last month and went over the annual report, you could see that your claims trend was way down. That was a combination of the changes that had been made, and in addition to some of your high-cost claimants were no longer on the plan. So you have to account for that. But, in my opinion, and Tony, tell me if you think differently, but I think your plan design is at an appropriate level. When I was here last month and I proposed how to manage some of that out-of-network spend, that's what we're trying to concentrate on now as a company, because we've found that it has a big impact to the plan design, but not leaving your members out there trying to figure out how to offset those balance billings. So we've got that advocate in place to help them if they happen to get balance billed on an out-of-network provider.
Okay. Well, then, talking about, so I'm going to assume the answer is no. I'm looking at the left side of this chart, by the way. I haven't gotten over to the out-of-network yet. I'm only talking about the in-network. You feel like we've found a pretty decent balance here with these rates?
I do.
Okay.
On your plan design, absolutely. I can't speak to the rates, but I do feel like on your plan design, it is a good plan design to where it needs to
When
be.
you say I can't speak to the rates?
The rates that are being charged to the members.
Yeah, for example, family coverage or
Right.
spouse or dependents, or even how much we're setting aside for an employee coverage. Okay.
I mean, but to talk to your annual deductibles and your out-of-pockets, those actually, believe it or not, are considered low in the standard that I'm seeing these days. I'm seeing an average of a $3,000 deductible. However, I wouldn't recommend any increases on that because let's see, in 2018, you didn't change your deductible in 2018 or 2019, but your plan design is running very well based on what your deductible and your out-of-pocket is.
That's what I was about to say, that I think maybe some of the good reports you've had in the last 6 months may be reflective of the changes that you made. So, and the other thing you did is you changed the way the drug worked.
Right.
And I think that's a huge part.
That's
Yeah.
been a big factor.
Yeah. Do you know how many on our plan hit their deductible, have hit their deductible this year?
I do not, but I can get that information for you.
Okay. Well, let's jump over to out of network and see, you know, we've raised this in past years to the point where now I'm asking, have we really caused a shift in employee decisions and really steer them away from out-of-network providers with these rates, or do we need to continue to make adjustments here to further hammer that point home?
Yeah, let me see here. What we're looking for is the past reports I had, what we had is out-of-network utilization. And actually, if you go to the PACE report, Tony, on page 7.
Yep.
And this really, I mean, so at the top, your in-network utilization percentage is 99%. So for inpatient and outpatient services, there was 100% in-network utilization. Your physicians, which you can't control the physicians when you're at an emergency room.
Right.
That's where my recommendation of the benchmark plan for 2020 is going to help some of that. It's not going to keep the in-network percentage going up, but what it's going to do, well, and it can. I just learned from a all-staff meeting we had a week ago Monday that because of this benchmark program that we're recommending, we have had 2 more ER physician groups become contracted or come to our network folks to become contracted. We've also had another large anesthesia group come in. And that's exactly why we are targeting our out-of-network providers. We know there's value, and those are really key areas to want to have them in network.
Okay,
Because
good.
members are have no control of the hospitalists that come see them. When they go to the ER and it's a true ER, they have no control of that physician treating them. Anesthesia, the doctors who are doing the surgeries are the ones who call in the anesthesiologist. And so the patient has no control over that.
So we as a plan don't really have that much control on forcing these guys to join in our network, or do we?
Well, you do.
Is that more behind the scenes, the efforts that you're...
You do in these programs that I keep looking for that will help your plan. My job is to always look out for the plan, but also to take care of your members. Because I know I don't want any one of you all sitting up there getting calls every single day, or sharing in that net, hearing from members every single day that their claims are just, they're not being paid correctly because the provider wasn't in network and things like that. So I work with Tony very closely to make good recommendations that will benefit everyone as a whole.
And I will say, if we ever find out or somebody lets us know that somebody they want to use is not in the United Healthcare Network, we always reach out to our UMR and UHC contacts, and they have provider relations people that contact those folks directly. I will say, though, comparing the networks between the 2 big ones, Blue and United Healthcare, they're very, very similar. Most every provider that's in Blue Network is in United Healthcare's network, because they have to be, because those are the 2 biggest carriers.
Yeah, that makes sense. Okay, well, guys, what it sounds to me, what I'm hearing is our out-of-network, we've found maybe a sweet spot where we've got our members trained that we really don't want you using out-of-network services unless you just get fooled into it. And so perhaps there is not a need to make any additional increases in out-of-network charges. Maybe we've accomplished what we want with 99% of us using in-network services. And then you were saying other things, Tony, that are important to hear as we possibly consider looking at a bid from TAC. When you go through a change in providers, a change in a plan, what I would call a major change, you know, if we think back, I know that Al and I were around after we made changes, you know, years ago, going from Health First to UMR, and how many calls we were getting and you were getting each year as our employees learned the differences in the plans. And there's just I guess I'll call it a learning curve that you've got to go through to figure out all the nuances of any new plan. And you got to be aware of that you will go through some tough times as your employees get used to, and their dependents get used to new coverage, understanding different terminology, understanding different rates and deductibles as part of the plan. And some of here we can tailor our plan in hundreds of different ways, and you'll have less tailoring capability if we go with somebody else. Okay, well, let's jump down to prescription drugs. Right now, we pay $5 for is it for a 30-day or is it for a 90?
That is the 30-day supply.
I swear I'm still paying $5 sometimes for my refills.
On mail order?
Yeah?
Yeah, well,
If they are considered preventative ones, then yes, you're going to pay the lowest copay. There are, it's
a list.
It's a list, and it changes frequently because as the FDA moves certain prescriptions from being considered a medical type to a preventative, and I don't mean a wellness preventative, I mean to stabilize a condition. That if you take that drug, let's just use diabetes, it's an easy one to throw out there, but if you're taking a daily dose of something for your diabetes, that drug may become, the FDA says, this is controlling diabetes for members, we consider it as a preventative drug. And a lot of times that'll happen when they know there's an influx of new drugs coming out that are much higher because they're new to the market. So they're going to lower the costs and try and get members to stay where they're at versus moving to where the drug manufacturer is going to advertise to everybody the newest and latest and greatest out there.
Okay. So we pay $5 for a generic. We pay $25 or 5 times as much for a brand name if you just don't want to do generic for some reason. And then a non-preferred brand. Tell us again what a non-preferred
Well,
is.
That same list she's talking about,
Yeah.
every carrier, every insurance company, Blue, United Healthcare, Cigna, Humana, has a formulary. And on the formulary, they've got their preferred brands and non-preferred brands. Sometimes it's due to cost, sometimes it's due to other factors. It's not always cost. It could be maybe how the drug responds to certain conditions. But whatever that reason is, it's the insurance company feels like that it costs more money to dose out those medications.
Okay.
So that's what a non-preferred brand is. They're both brand names, they're not generics, they're brands, but some are cheaper or more effective than others, and that's the difference between preferred and non-preferred.
And obviously we charge more for the employee who wants to use that non-preferred brand because it's going to cost the county quite a bit.
Right. But if you ever have a situation where the actual cost of the drug is less than the copays, you should be billed the lower amount.
right.
Okay.
So there may be some brand name drugs that their retail cost is less than $25. You should be getting charged less than that in those cases.
Okay. And then a specialty drug, have we even had any specialty drug usage?
You actually do. You have, so your conditions that are related to a specialty drug is inflammatory conditions. That not a surprise, but that's out there. But you do have the Humera Pen that is being utilized right now. Humera is a drug that's been on the market for a while. Well, they were about to lose their patent, so what they did was they changed up one of the ingredients and then made it into a pen form, and so now they've continued their patent, and so they can stay as a specialty drug. And they also increased the cost to it.
What does Humera treat?
Humera treats inflammation,
Rheumatoid
arthritis,
Okay,
psoriasis.
arthritis.
A lot of
cirrhosis.
different things, actually.
Yeah, it was primarily for rheumatoid arthritis, but it's been found to treat other conditions as
Okay.
well.
All right. And then,
And the maintenance, this was one of, I think, Sharon's questions on the list that what she'd sent you. It's not mandatory, but after they go through 3 fillings, if they still want to use the local pharmacy, the rate does go up for those maintenance drugs.
2 filling. So, see, I thought that we had made the switch to mandatory mail order, but on maintenance drugs, but
No.
we haven't.
No, they still have the opportunity to buy it at the local. They're just going to pay more money to do it.
But we've also seen a significant increase in our mail order utilization.
So, yes, our last report for, through 2018, your mail order utilization was at 32.5%. And our average book of business is actually at 14.75%. So you're double what the Optum Rx average is.
Gosh, what can we do to get it up even more?
The next step would be to make it mandatory, and they wouldn't be able to fill their maintenance prescriptions at the local pharmacy.
I honestly think in the people that I've talked to, it is nothing more than sitting down at the computer and setting up that account.
And your doctor, I mean, if it's the first time or renewal, your doctor, there's 3 ways to sign up for that. My doctor sent it automatically.
Yeah.
I did have just a few left to get me to the where.
Mm-hmm.
I save $35 every 3 months by my week. Where it's $15 per month at retail. And you're charged 10 for 3 months.
And thank you for, saying what you said, Sharon, about when you're at your doctor's office. That's something that rolled out earlier this year, behind the scenes. You and I wouldn't see it. It's called Pre-Check My Script. So if your doctor is, when you're at your doctor's office for a doctor's visit, if they're working on a laptop or a computer while they're in there with you, then they're set up with what we call electronic medical records. And UMR and Optum Rx has contracted with the 4 largest vendors who do that. Not every doctor's in one of those 4 vendors that do the electronic records with us, but if they do, so while they're treating Sharon and talking about a prescription that they're going to either need to refill for her or a new one, they'll be able to tap into, the nice thing is about the doctors doing this is they don't have to log into a different program. They're already in Sharon's file, they're already in all that information. They just go to the pharmacy side of it and they pull up the prescription. It will tell the doctor whether that's covered or not for her. It will tell her what level it's at, either generic, or brand, or non-formulary. And then he or she can say, I can do a mail order for you. They can give her a 30-day supply and then at the same time request mail order to go over to the Briova pharmacy, and it's automatic.
What's Briova?
That is Briova is our specialty pharmacy vendor. It's part of Optum Rx. They do nothing but specialty, but the Optum Rx mail order service is where that prescription would go from the doctor. So we've actually, no longer are the days where your doctor writes you a prescription, not even for a retail prescription, where you have to take the prescription and go to your pharmacy and hand it to them and hope it gets filled. Now with that Pre-Check My Script, while the doctor's typing it in is what they want you to have, it will tell him or her, that's not covered under Sharon's plan, and here's the alternatives. And then he or she says to Sharon, okay, I gotta write you something different because your plan doesn't cover this. So there's no longer the surprises. The other nice value to it is if a drug requires a prior authorization, meaning it needs medical review, the doctor can submit the authorization right there at that time so that when Sharon needs to go get a prescription down the street at the retail pharmacy, it's filled. and ready.
And all these doctors are using that software, we assume?
Most are. And the reason why is because that was part of the Obamacare requirements, is that eventually it had to get to that stage. So not all of them are using it, but I would probably say, what, 80 to 85%?
I mean, my doctor holds a laptop. I mean, now everything is on digital files. I mean, and I know that my husband
was a
was the
requirement
doctor.
that
He
he
went
had
to
to do.
Berlin last week, and he said that, you know, everything got refilled right then during that visit, so.
Okay, well, let me clarify here. Let's say we have a person on maintenance drugs who's been going to the local pharmacy, and January 1, we force them to go with mail order. At the time of their visit, say at Dr. Burling, we just say, now the county's requiring me to go mail order, and we use Optum RX, so will you send that script to them? Do I still have to go to Optum RX and set up an account in order to receive that?
Yes, and the reason why is because you'll need to put a form of payment on file, whether it's a debit card or a credit card.
Sure, okay,
To
yeah.
be able to get the prescriptions sent to you automatically. And then once that's submitted in from the doctor and you've set up your form of payment, you can also indicate whether or not you want auto refills and how you want to be communicated when they do the auto refills. I mean, technology is there now with the pharmacy side, that you can elect to have an email sent to you, they will text you. It's the member's choice as to how they want to be notified, setting up their prescriptions on mail order.
Yeah, yeah. And now that I've done it, it's absolutely wonderful. What we
Our book has 4 ways. The physician can actually fax something in too, or Optimex can call your physician.
I have a problem with mail order. I was taking it in the car, and it didn't come. And I didn't realize it until it wasn't there. And when I called them, they said, oh, that's been pushed out to 2022. And I'm like, why didn't someone let me know? You know? And so they had to go ahead and let me get it at my clinic pharmacy where I trade, and I had to make an appointment with the doctor, and he had to change it to a new drug. So that was an additional.
What do you mean by pushed out to 2022? It was no longer a covered medication?
It was no longer a covered no, it was just no longer available.
Oh,
So that was the words they used when I was talking to them. So I changed to the new drug, and before I finished the first prescription, they mailed me a 3-month supply of Invengar. So I had to call my physician. He said, go ahead and take it. You know, it's not, if it's unavailable, it's unavailable.
and that's where the pre-check my script, does your doctor,
But no one notified me from
you didn't get any emails or phone calls or anything?
I got nothing.
That is unusual, because it's not supposed to happen that way.
I agree.
When did this happen?
That happened maybe in the spring.
Anytime anything like that happens, call us. And we
Yeah.
can kind of see what's going on.
Yeah,
I took care of it.
Did you have another problem? Did you have a problem?
No, I still can't get it. Reason what makes me go there, they still say generic. They tell me before I didn't take it twice a week. Well, now the generic is twice a week, and there's no question.
And
feel it.
so a lot of it is not necessarily, so I had another example of a different client who, I thought it was excessive, but it was because it was oxycodone. The doctor wrote a prescription for this person who had back surgery. He wrote a prescription for them to get 10 oxycodone pills a day. Well, the FDA, we follow FDA regulations. They say the maximum, I know, the maximum is 6 pills a day. So back to your situation, it could be that the FDA requires that, no, there doesn't need to be 2 a day on that generic tablet. And that's where, unfortunately, I wish doctors would explain more on
Twice a week, but I can
Oh,
get
twice
it
a week.
my regular ones, no problem.
But the mail order, you couldn't couldn't do it,
The mail order company's Optimal RX, just that one.
Optum, OPTUM, correct.
So you set up online?
Yeah, and it's wonderful.
Yeah, and she really good, they still really good.
You can buy one time
I've
prescription.
never seen it, how to do it.
yeah.
Never called.
I'll be glad to know.
I'll do it.
The thing is,
Once you get it
that
set
your
up, it's
pharmacy
wonderful. If you're on
should be using the same.
blood pressure, you take their blood pressure medicine, my cholesterol. I give you 90 days supply.
And that may be,
So then I have to get a hold of the doctor again, get a prescription or something? I have to go to the doctor.
No, when you set up on UMR and you plug in the drugs that you take, they'll contact your doctor.
Oh, that'd be easy done.
Yeah, and then when that prescription runs out, they'll Optum will notify them again, hey, Dr. So-and-so, John needs a renewal on his prescription. It's all done, whenever you need, just keep coming in. Good. I like that. Oh, it's great.
So is that gonna be mandatory?
Well, that's what I'm getting ready to ask you all. I thought we had already changed over, and it's only mandatory, well,
It's only mandatory on the ones you take daily.
correct.
Because I'm gonna go to the doctor and they may give me something for a sinus next week,
Get
and
it
then
cut on,
just go get it, yeah.
Special antibiotics, you
Yeah.
get that at clinic or Walmart or
Yeah.
whatever, but your daily stuff.
Yeah. It's twice a year.
So,
Not every
does it
day.
save us money doing it mandatory?
Absolutely.
For St. County?
And if there's a negative.
A lot of people won't like that.
Well,
We were
the
with
reason they don't
the
like
school
it is
system
they
had
don't
them do
want
it that
they
way
don't
one
want to
time.
have to get on the
Yeah, I had to
computer
do
and set
it.
up.
Yeah, it's gonna be hard for some.
Well, yeah, some of them don't have internet or computers, so too, though. I've got a couple of them that don't.
They can, so if you don't, just like with Teladoc, you don't have to use a computer. You can
Right.
call OptumRx and give them your payment method over the phone.
Right.
Because you want to do mail order, and they will take that information over the phone from you.
Okay.
That's good to know. So they'll set your new account up over the phone?
yeah, it's step, let's see. Did we say that here? Your physician can call.
And physicians can call in your prescription, but I'll get you a new updated brochure, Sharon. We'll get some talking points for the new guide for next year.
Well, this is a small thing to ask, and what I'm going to suggest as a change is that effective January 1, maintenance drugs must be ordered through mail order Optum RX. Now, you can set it up on your computer, you can call it in with the telephone, but once you get it set up, can't imagine anybody that's not going to like it. There may be these little oddities that pop up, but I've had nothing but a positive experience, and I think there's opportunity for a lot, even more cost savings. We've already reaped some of the benefits. Let's continue that push.
Would you like to have at least 2 fills at retail? And then when they go to try and get the third fill, they'll be told you have to go to mail order?
Yeah,
It's a highly recommended thing.
I thought we've already done that. We're already doing that, aren't we?
You've got 2 fills and then it's suggested. Now, when they go get their third fill, they'll be told, sorry, you can't, or you have to pay the full expense of the drug with the mandatory mail order, or contact your provider or go to mail order.
I
So
think
it'll
you
be
should.
mandatory.
Because there's some people that are not doing the mail order now. They're still thinking that they.
Oh, yeah, I know.
Are we still gonna be paying the same though anyway, whether we do it or not next year?
So with the mandatory, if the member says, I am not doing mail order, they will pay the full expense of the drug.
No, if we
and the plan
don't
won't.
elect to do that, we still gonna be out, it's gonna still cost us the same next year?
Yes, as long as the members stay on the same types of prescriptions. Now, if you had an influx of specialty drugs come in, and the utilization went up, then the plan would cost more to the plan. So it's based on utilization as to what the plan, there's no per member per month cost to the plan. This is all going to be claims utilization.
Yeah, the more people you can move to mail order, the better it is for your claims costs for the county. Because the county.
I'd rather try to just promote it to everybody and try to prove to them like you got a good testimony. I'll try it.
We tried
People
that
that
last
can
year.
try it, I mean, it really helped me, but there's gonna be people that have
Well,
several
we tried it
prescriptions and
last
people
year,
with no
correct me if I'm
internet
wrong.
to be paying.
The education of the employee pool. It's really easy to
Well, you've got,
But it can be easily rolled out with the proper education level workshops, having your employees mandatory workshops, where employees have to come and sign in and learn how to do it, then you know that you've provided them what they need in order to do it. Because if not, it's been simple for Sharon, not so simple for Joan. You're gonna have those variances. Well, ultimately, everybody is gonna be calling Sharon or the auditor's office. So I don't know who takes on that role of educating the employee pool, but if it becomes mandated, then you're gonna have to have some form of educating them about it. If it's just
I think that education can be on one piece of paper. Option 1, get on your computer, log in here. Option 2, call this 800 number.
We have to look at the age immigration of your employee pool. And I do understand that a lot of people are highly advanced in the technological field. But I personally know people, and I know from having these issues in the past, even working in a medical center, even people there, it's not as simple for some as it is for others. And then they'll get frustrated because they're having to pay full price, and then you get that kickback from them. So, yes, I do agree for me, it would be quite simple to probably do it, but for some, it just will not be.
I just asked Chris if we could get a list of all the members that would be affected by moving to a mandatory maintenance, and then actually addressing those folks.
I wonder how many people do this now on mail order in our county?
you've got 32% using the mail-in
32%.
program.
Yeah.
And prior to that, you had zero utilization.
One of the
or almost nothing.
big changes a year ago that occurred is when I sat down and talked with Sheriff Ingram about this. He got it. He said, "I'm going to get my guys on mail order," and he did. And they spread the word around there, and I'll bet
But
you.
if we have a list of everybody in the county that's on a drug that would be affected by the maintenance mandatory rule,
Yeah.
and then you reach out to those folks, and we have those in a meeting, I mean, I'll come and talk about it.
Great idea.
And then we could just say, okay, you were the ones affected now, and then make sure in open enrollment, you're telling everybody else. If you ever, if you get put on a cholesterol medicine or a blood pressure medicine or anything you take every day, then you can get 2 fills, at your local, get used to it, make sure it's working, because sometimes people don't stay on medicine for a long time. And then that way, if it does, then tell them how to get the maintenance done. Is that doable?
Yeah.
And I could go over that with you on it too, but when we've done it,
Yeah, yeah.
And I had a debit card one time that went out of date, and they didn't ever call me, and I had to go get a prescription up here at the pharmacy, and I called them, and they said, "Well, your card's out of date." I said, "Why didn't you ever call me? Somebody should have contacted me over this, because I just don't think about that." But so I had to go up here and get Dr. Williams to give me a prescription. I don't think you should be charged for something like that. So that's
They emailed me when that
well, that
happened.
didn't happen to me. They didn't. I called them and they said, "Well, your card's is out of date." And I said, "Why didn't you call me?" They didn't do it. And I told them I'd give them my other card, and they started back. But I had to go up here to the Dr. Williams write me a prescription for my heart medicine, all my cholesterol and all that. So, it's just some things
Yeah,
that does not
typically,
happen.
When I've done mail order, they text.
Well, they didn't text me.
I think it's also how you set up your notification. Do you,
I had them. I said, "You're supposed to call me." Yes, but they said, I said, "Well, we need a credit card."
and
And
I'm going to go back and ask if
So
they
I
can
don't think you
explain
should
to me.
be. I don't think an employee should be hindered because something that they did that we could have been avoided if they'd have contacted us.
Sure, I'm going to go back and ask what other preventative measures we could put in
Right.
place on that.
Yeah, because, like I said, in emergency, I don't think somebody should be charged. That's not, when it's out of their hands. But if I do the medical, I do the prescription over the phone, which is good because it's at the mailbox all the time. But that one time, it didn't.
I'm going to check. That's
And,
good. Yep.
'Cause I put it on my debit card, it went out.
Yeah.
And then,
Yeah, same thing's happened to me with other
Yeah,
stuff.
mine too.
Yeah.
I got an email from Optimarx that my debit card had expired.
I didn't get
So-
nothing.
I'm trying to think how they notify me. I can't remember if it's text message or email.
I've signed up for both, so I was getting both of them. That way, you know, whatever I paid attention to that day.
Well, that seems like a reasonable,
Which I have done, I like it, 'cause it shows my mailbox, you know, I don't have to go to the pharmacy to pick it up. But,
would you all be willing to make a change to the plan starting next year, requiring maintenance drugs to be mail order after the second refill, and knowing that Tony will get a list of those affected and we will make direct contact with them for a training day or an offer to, you know, bring them to my
It's
office?
just gonna take a commitment for us to help a few of our guys and ladies. We're gonna have to help them.
Yeah.
It's
That's
gonna
right.
be
But it seems to me a small price
process.
to
And
pay.
then most people like me, I'll do it. I'll do it today. It's gonna be
Reap
nice.
ongoing benefits once you have them set up. So at the end of this meeting, I'm gonna go to item number 2. We're gonna have a chance to, you know, consider and implement any changes. So that's one thing I'm gonna ask y'all. So before we get to that point, how do y'all feel about that? Are y'all willing to make that change?
but they do have it clarified now. Since I went and get my debit card, they updated everything, so maybe they will this time.
And like I said, I'm taking this back.
Okay.
It's point of reference to the Optimarx team and find out what has
Good.
occurred and how we can fix that for the future.
And also, did you say that another benefit to the employee is it gets you a 90-day prescription for the 30-day price?
Is it 30-day or is it 60-day price?
60-day price, 60.
It's a
60-day
60-day. So you are saving one copay every
Right,
every
$30.
90 days.
Okay, that's why I'm paying
That's a pretty good
I'm
deal.
paying $10 for my stuff. I'm paying 2 times the generic on my generic maintenance drug, but I
Right.
get 3 months.
And what you put in place is if you didn't choose to go to the mail order because you haven't made it mandatory, you're charging the members $15 to get a to get a 90-day supply at the retail. So they're paying the true 3
40.
months worth on a generic.
Right. It'll be benefit for them if they would do the mail order.
Right, because they would have paid 10 instead of
Right.
15.
Okay. Well, let's move on. I'll still come back to that at the end of the meeting and ask you for a vote on that.
If you were to elect and vote to do the mandatory mail order, you could actually remove, if you wanted to, because you won't be able to get any more, if that's put in place, you won't be able to get a 90-day supply at retail. So you could remove that 3 copay charge within the guides and not have to talk about it to the members anymore either.
Okay. But again, that's only on maintenance drugs.
Right.
You don't
Right.
have to log on to get you a 30-day specialty medicine when you get a cold this winter. All right, let's look down. Any other, anything else you think that we should consider doing to improve our prescription cost?
No, what do you think about specialty?
I don't think they have a specialty problem at the time. Is there anything you can implement now that would head off anything in the future? You've already put them
In premium PDL.
Yeah.
Yeah, so that list, so you're on what we call our premium PDL program, which excludes the top high-cost specialty drugs. The member can't get those. There are alternatives that they can get. So that's already in place. And so, yeah, I agree with Tony. There's not a specialty misuse like I've seen in other.
Person with one drug on a specialty, right? So just one person?
No, I think it is, yep, one utilizer. Yes, you are correct. That's using the specialty drug, and it's the Humera.
That's really pretty good for a group this size.
Okay.
And you've already made it where it's more expensive to do it because obviously those drugs are much more expensive to the county. But still, being able to get Humera for $150 when the actual cost is what?
$15,000. It's $15,000 on a 30-day supply for that Humera Pen.
I'm in the wrong business.
I know. You're absolutely right there.
And for somebody that needed that, they're paying
$150.
$150. All right, well, let's look at employee payroll deductions as they are right now. Of course, our employee only is provided at no cost to the employee. If they want to add their child or children, regardless of how many there are, they go to $175 every paycheck. Well, not all 26 paychecks, but 24 paychecks. Is that right, Sharon? 24. So it's essentially twice a month. So $350 a month is the way to phrase that. $350 a month. So Barbara, I was a little off when I told you family coverage was $400. It's really $600. I was thinking about what it cost me, and that was just my wife. So employee plus spouse is costing you $425 a month. And then to cover your entire family, regardless of number of kids or wives. If you have multiple wives, is it the same? $600, nobody laughed, $600. $350, $425, and $600 is your monthly costs on those. That's still behind the times, right?
Well, much, much lower than the average.
Okay. Knowing that, fellas, is there anybody that would be interested in raising that up, however so slightly, this upcoming year? I'm assuming that's a no, but I'm still going to give you a few more minutes. Okay.
While you're on the subject of premium, this may be further down in your agenda, but the wellness system, you know, the biometric screen and the CHRA, the two requirements you had, if someone does not meet those two requirements, what is the penalty for next year?
Is it 100 per month?
That's what was discussed.
Per month. Yeah, well, that's
And it's
what's,
the same all year.
that's what's going to be implemented January 1 of 20 for anybody that has not done both of those. And do we have any idea how can we find that out?
Carol sent an email last Wednesday to Sharon, to all of us, that can be sorted, and you can see who those people are. That's on a list of one of Sharon's concerns.
Is that proprietary information?
It is, because it does have the employee and the spouse name on it. So those in the room that don't have the PHI access.
How do we pinpoint address these people who are getting in danger of being tagged $100 a month, and there will be much wailing when that happens.
I did it by the info reports last year. I pulled them into the employee list and marked off everybody that had it done.
Yeah.
Spouses that they
This
had.
was last month.
And then I contacted their elected official and said, you have some people that understand, will you remind them? And I had some that were very beneficial and helpful. Some that were starting to come in pretty fast after that. It takes a little time to go back every month and just check and see.
But right now, we don't have a single employee that's paying any penalties for anything from last year.
The last 2 years, we've had 100% compliance.
But it's because you accepted vision,
Yes.
vision exam, anything counted as a
Yeah,
wellness.
yeah, but that was still a big jump
Yeah.
going from annual,
So
from
as of the
zero
end of-
annual checkup.
At the end of last month, you had 27 that have done nothing. You've got 16 that are incomplete.
They started it, didn't finish it,
The CHO.
and/or the last.
But this report can be sorted. This is an Excel report.
it's an Excel document.
That goes to, and it goes, and it's not available on the portal, but it goes every month to Sharon, to me, to Chris, to Jessica.
Sharon just, I mean,
It
Sharon, Carol
went
emailed
on
it
the
to you.
27th,
27, I'm going to go back.
the 29th, I'm so sorry. 7/29 is when it was emailed in July. So there will be an updated one from this, but it's just an Excel document, and I can sort it for you if you need me to, where it's going and it's showing who's left. Now, I mean, and I don't know, my thought was, in Sharon's concerns here, is that maybe the department heads, you know, y'all know who those people report to.
Violating HIPAA, if I
No,
said
well,
the spouse is not-
we can't give it out to them. What you all do in your agreement between the commissioners, I can't say any of that.
I can tell an elected official, this certain employee's spouse is not being there or something.
I
Well,
just couldn't send it
if
to
a spouse, what must a spouse do, a covered spouse?
You suggested that the spouses have the wellness.
But I don't
checkup
think that we
and
put
CHR.
in the qualification.
I don't either.
We just allowed them to come to the biometric screen if
If
they
they fail to
wanted
get their biometric screening and CHRA, there's no penalty to the employee?
Well, I don't think you can impose a penalty to a spouse.
Right.
Yeah, a spouse doesn't, you can only impose a penalty to your people, to the people that work for Titus. I think what we said when we set up the biometric screen was, you go, we're gonna allow these spouses to come if they wanna come and just get it done and see.
How
And
can I incentivize a spouse to get this stuff done?
the way Higginbotham does, that for the people who want to get a biometric screen that are covered on our insurance, that person gets like
A gift card, we talked about that, but we can't have a negative incentive
Not,
No, you can't have
for
a
a
penalty.
spouse, even though we're giving a bargain price on spousal
That's against the
coverage.
GINA, that's another federal law.
That's
GINA rule.
federal.
Yeah.
And why we gotta do it? We get our insurance cut off if we don't do it or something, period? Or is it a
No.
big discount we're getting cut, or it's just better for y'all?
well, the county made
It's
a
not, it's
decision.
not to us,
Yeah.
it's to incentivize your employees to go and go to a doctor.
Before it's too late.
Yeah, before they have a
Catch something early.
stroke or,
Identify problems that could be treated that can save you from big problems later. And if you don't ever go to the doctor, you may not ever find out.
but according to this last month's list, you're really close. You're very close. Yeah.
What do you say?
Three call this week.
What did you say? We're really close. That didn't sound really close.
27,
They
no
haven't-
activity.
No activity?
And 16 that are incomplete.
27, that's a big number.
Out of,
Compared to the prior years, they'll get in there.
We have 140.
Is that complied with just the wellness? That's not complying with the survey y'all sent out?
It is,
That's-
no activity means they haven't done anything. They haven't.
Well, that
Both
survey,
things they have to do.
that survey, it took me forever, and I finally just did the pay, because I couldn't get on the website.
I know, you and I had
Yes,
fun trying to
and
get you in there.
then the,
5 people that came and had issues.
yeah, then you get this, paper survey takes you 35 minutes if it's a page just like this here.
Yeah.
And, I don't agree with that because it's, they ask a lot of questions that, it's personal to me. And I just don't, you shouldn't be penalized because you didn't send the survey in. That's my opinion. Because it took me forever to do it. It just discouraged me over the survey.
Most all insurance carriers now, when you're implementing a wellness plan, will ask for that health assessment. Blue Cross does it, Cigna does it.
Well, I just wish I would like to set a workshop to help everybody do that instead of just, it just drag it out. It was a waste of time. I sit on the computer, and I know there's guys that did the same thing, and they just got frustrated.
And there's a paper form.
Well, that's what I'm saying. And then they fill out the paper form, and it takes them 45 minutes to do it. You just got to sit down and do it. And like I said, if we're going to paper form, we need to set up a
Most
workshop.
of us that are on daily medications and stuff are going once a year anyway to get our medication, get our blood work done, and it paid for through the insurance, so
The problem
It
is
just
that
causes
you've
so
always
much
got
trouble.
some people that ignore warning signs.
yeah.
And you've got folks that may be almost up to the edge of their sugar's really high. They might be almost diabetic and they've got a high blood pressure situation and maybe high cholesterol. Those are the things they check. So, I know I have a husband that probably would never go to the doctor should I not push him because he's been very blessed and he doesn't take anything. So, anyway. So,
But yeah, they do check all that.
They do.
Yes,
they do.
So you have the two different steps.
It's obviously, y'all voted last year that those are the two criteria on the wellness plan that you base this year's thing. And UMR gave you how much credit for implementing the wellness?
I actually got it increased from $2,500 to $5,000 to help offset the cost of these programs. And my intent is to allow that $5,000 credit to be used again or applied and offered again for 2020.
But it's the court's decision whether or not you do a wellness plan.
Well, I don't have a problem with the screening deal. It's just the survey deal that I had a problem with.
And the survey is used to just
Make recommendations for
based
lifestyle.
upon, it's like if you have somebody that never exercises, smokes excessively, drinks too much, obviously those are lifestyle choices, but they ultimately affect your health, which ultimately affects what the county pays out in claims dollars. So
I just think there should be a better way.
I agree.
There's no way to do it, just going and getting our blood work done up there once a year.
To get the
You have to
full
do both.
results, it needs to have both pieces.
What is it if you just do the one?
I don't think you get
There's
any
no
of
way
the
they don't
result
let you
back.
do it.
Yeah.
So it's 27 and 16. When we had our elementary happen, so it's a big year.
Yes.
And that's a 6.
Well, no, actually, what was it that we decided on? The current enrolled had until April or October 1st to get it done? November 1st. They have until November 1st. So Sharon has time to do the payroll updates and everything.
So we're still looking at 4 months from that day.
Right, yeah.
For the 27th, because mine is in August. That's just one of
And I have a question on that.
So I'll go on the
Employees that are part of labor and care, like
Right.
professionals too. So there's certain points they won't get that fast. They might be getting to get regular water.
But they could do the paper.
And what I've had them do in the past, because we didn't have the specific requirements of the blood work or anything, is bring me something from the doctor showing they had it done, and then I'll mark them off the list. But I don't know if you're wanting this done where everything goes straight to you, Mark.
Well, if anybody didn't do, and I was reading, I may not have answered this question, but if anybody missed the on-site biometric screen, of which you had really, really good participation.
Absolutely.
You really did.
Yep.
If there is a paper form that anybody now, until whatever y'all said, October, November, can take that form to their doctor and they do the test, and then the doctor sends the form in, and that satisfies your biometric screen.
Right.
Yes, I'm satisfied.
Oh.
People that come in later are.
New after October 1st.
May have time, may have trouble getting
typically you exclude, you give them a pass
And this,
for the next
and
year.
I have, if they come in November or late October,
Yeah,
they're on to next year. Well, yeah, they have to start by October, be on their October by January 1st. Yeah.
So are there some names on that list of spouses that we have no clout over anyway?
yeah, we have the names of spouses.
Yep, we do have the names of
We've
the
got the
spouses.
names.
Non-participating spouses that we can't do anything about.
Right. You cannot penalize the spouses. Period. You were just giving them the option to go attend that non-interest rate, which a lot of them did.
Do we require, do we still require the spouses to get an annual physical though?
Well, it's highly encouraged and your benefits reflect it because it's paid at 100%.
But you can't penalize them for not doing it.
You can.
Cannot penalize them for not doing it.
Here we are,
But you can put in a spousal
providing
surcharge
coverage
on
at
the
a
other
cheap
coverage.
price. Can we have a higher dependent rates and offer discounts?
Well, that's what you just said.
I said spousal surcharge if they have other coverage.
Oh,
So if the spouse is eligible to take their own insurance if they work and they elect not to take their company's insurance, but come on the county's plan, you could apply a spousal surcharge, meaning you could charge that.
No, we're not
employee.
gonna get into that.
Yeah,
And what about a dependent that's under 26 and they're working?
you can't do anything on an under 26.
Since they're 26.
Yeah, they can be working and have their own insurance and be on
I
it.
got one.
I've got one too. But you can't do any dependent surcharges now. It's only on the spouses.
Okay, in order to get full compliance so that we don't have anybody crying on January 1 that you're taking $100 out of my paycheck, what would be your idea?
If they're not showing up on the UMR, in the past, they've already something from the doctor showing that, is that what you're asking?
No, how are we gonna remind them, hey,
Oh,
you're
remind
getting,
them.
you're,
And you
you
can't
haven't,
do that. It's got to go into
Well, that's
UMR.
what my question was, this year, since it's different.
So if they have not done anything, I suggest maybe emailing them the physician's form and saying, take this to your doctor between now and, what did we say, 11/1, 10/1? Is it 10/1?
No.
11/1.
And another question is, those forms when you mark for the employee, I understood in one of our meetings that they have to go
Bless you.
through their individual form. But I can't see anything identified on it, that if I printed one and whited out my name and then copied it, I could hand in that form. That I can get the, from the UMR site where they have to go print
I
their
thought we
form.
sent a
and
blank,
take it to
sent a
the-
blank.
I just don't know questionnaires.
You don't have any physician forms?
I did tell everybody to go to UMR site.
We can get you.
Yeah, we'll get you paper.
Well, that's good.
Physician left.
You can talk about that later. Because I couldn't see anything identified on my form, I just printed one.
so you don't have any of those blank forms that they have to take to get the doctor to complete.
Yeah, that's what I'm talking about. No.
We'll get some
We'll get some.
ASAP.
That's better be better.
Okay, well, still, how are we going, what is the route we're gonna take to notify these people so that this court isn't having to consider, are we gonna waive or not waive somebody's
What I
$100
did in the
charge?
past was take my employee list and the list from UMR, and anybody that wasn't.
Would there be anything wrong with her giving that list to my Carolyn to be that watchdog?
We can add Carolyn really quickly.
Add Carolyn
Add Carolyn.
as an authorized user on that PHI.
That way I can relieve you of some of that, having to keep following up on that
But it's like every
checklist.
other day.
Right.
I mean, here's an idea. If Carolyn can get these 40-something people together, I'll come and talk to them and tell them what they have to do.
That's not gonna happen.
Okay, whatever.
But we can make a serious phone call to that department head, say, do you understand that John Smith is getting ready to have to pay $100 a month for his
Extra.
insurance
And that's what I
coverage
did in part of yours.
next month, you know, starting January 1 if he doesn't get this done? And what does he need to do?
And the
Well,
officials were
here's the
helping.
instructions.
Okay, so add Carolyn as a PHI.
How many people haven't filled it out? Said 40?
Well, let's clarify what hasn't been done. We're not saying they haven't gotten an annual physical. We're saying they haven't done their biometric screening.
27 people have done nothing as of.
They haven't had a physical even.
We have not had the biometric screen, have not filled out the
But they may have gotten their annual physical.
If they had their physical, they didn't do the physician form and send it to us.
But even if they've already done their physical, we can give them a form.
And they can give the
actually,
doctor.
we can give Carolyn the forms. And if they tell her, I've already had my physical this year, then she can email them the form and tell them, take this to your doctor, have them submit it, and you'll be good as far as the physical part goes. Y'all need to decide what you're doing about this HRA thing.
What's that?
Health risk
Oh, the
assessment.
survey. I thought it's mandatory.
Well, it was.
It is.
Dana
There's
mentioned that.
two parts.
We don't like that.
There's two parts. There's an online health
Yeah.
risk assessment, and then there's a physical with your doctor where he
Yeah.
fills out a specific form and
Yeah.
sends it in to you.
The online deal, it is a pain, but I just didn't think there was a way out of it.
Well, I'm sitting there thinking, I don't know, but I'm thinking I've got four guys. 3 of them went on the computer. They all got the physical, but one of them did it by hand.
Yeah, I
You know, by.
Yes,
and
we
pay,
got
but I don't
hand
know.
copies
How
to
do
fill
I
out.
know? I just assumed that the rest of them went on the computer, because I don't know. I guess I can check.
We'll be able to tell
We'll
you if
give
they
you
did
a
it or
call.
not.
If Carolyn finds out, she'll give you a call and say, hey, employee number 1 and 2 need to do this, this, and this.
But you still have the paper.
Yeah.
And y'all included retirees in this as well, right?
How many?
Retirees. Yeah, 'cause
How
I'm
many
seeing-
retirees do we have now? Well,
That's 15 and 30.
He's retiring, right?
Yes.
and if they haven't gotten their physical, they can kill 2 birds with 1 stone. I'll go get my physical, and I'll take my biometric screening form for him to fill out while I'm there, and I knock 2 of those out. Because we haven't removed the physical requirement to go physically to your doctor, have we?
No. Oh, well, it's a biometric screen. It's really not a physical. It's answering the questions that are on, it's basically cholesterol.
Did we remove the requirement of them having to go to their doctor annually to get a wellness check?
No, we did not. Well, if they went to the biometric screening.
That served that purpose.
That served that purpose. Yes,
Same one.
correct? Like, if they went to the biometric screening, that served the purpose as
That
well.
served it as the wellness.
Yes.
They can still go get their physical
Yeah,
with their
still pay
physician,
100%.
but when they, for example, can I use you?
Yeah.
She wasn't on our list, but she said she's going in August for her physical, and she was afraid she wouldn't have time. Well, she did the biometric screening, so she's taken care of as far as, and then she did the CHRA.
As far as the county's requirement, she still might want to go for a physical.
Exactly, and that's what she's gonna go do, absolutely.
And I stress that to new hires, just because of the biometric, that is men and women, we still have testing, we have to have that, it's still pretty.
Right, exactly.
Okay.
But as far as the requirement for the county for the extra fee to the payroll, the biometric screenings took care of that for anyone that showed up and on there. And that report Carol sends shows who's completed and who's started it but didn't complete everything. Meaning, and that's more on the CHRA. They went online, they logged in, they started filling it out, probably got bored or agitated with it, went and did something else and forgot to come back and finish it.
All right. So you'll get Carolyn on that list.
Yeah.
Okay, why don't we spend the next few minutes going over going over Sharon's comments?
Can I make a suggestion before we do that?
Yeah.
I don't know why I've never thought of this before, but probably because UMR, United Healthcare, had started a bundling program. You've probably seen other insurance companies talk about it.
Bundle and
And
save.
this might actually help some of the issues on Sharon's list. Right now, you have Guardian doing vision, basic life, and fall life. So, if you let United Healthcare take over the voluntary vision, the basic life, and the voluntary life, that would eliminate the Guardian portion that you have to do, and everything would be on United Healthcare. Plus,
Are they fully insured?
huh?
Are they fully insured?
Yep.
Okay, we can do it. And so what Tony's saying is, let me take those products and go to the UHC side of the house, which is our sister company, because UMR is only self-funded. I can get you a quote to match what is being offered under Guardian, under the UHC product, fully insured. UMR can do the billing for it, and we can send them the eligibility piece of it, with the exception of the voluntary life. But that's a self-bill, so we don't ever get censuses on that anyways.
Could you get it cheaper? Could you get it cheaper?
That's what I'm gonna work for,
Yeah.
plus.
But instead of matching them, I'd like to see it get cheaper.
Well, and I can, if I can't get it cheaper, I can match what you currently
What are we
have.
paying, what are we paying?
Well, the rates
Your
are different.
Voluntary vision, meaning you're not paying any of the vision. You're paying for the basic life, which is $50,000 per employee. Huh? Okay, $1,525 a month. So the vol life would just be a seamless move over to United Healthcare. What I would like for Chris to do, and I have personally moved a lot of business from Guardian to United Healthcare. Their vision plan is with Spectera, which includes Warby Parker, which if anybody here knows what Warby Parker now has ads on TV. Tell your kids, you got any kids, they will know what Warby Parker is.
Yeah, I've got them.
Okay, so it's like Warby Parker will send you, like just like on the TV, they send you like the glasses made and you try them on at your house. It's a great vision plan with United Healthcare. And we have the opportunity, by moving the vol life, we possibly could get a fresh guarantee issue. Ask for that.
Okay.
So that means anybody
We're
that-
talking about possibly leaving Guardian.
Yep,
And leaving, who does our life?
Guardian.
Guardian does life.
But what I'm thinking, this consolidates for Sharon one carrier.
I love it.
You
But there's also some added
would have,
values.
the other value is that you've got the bundling discount, which could come off of your medical.
Right, so we can offer a discount rate, and it just increased, and I don't know the number off the top of my head. Huh?
Is it 2.5?
No, we don't do percentages, we actually do a PEPM rate.
Okay.
So it increased, and I apologize, I did not see that, what the increase went to, meaning that, I do know right now, if you were to bring your voluntary life, your life and voluntary life and vision, I could offer you $2.20 off your medical PEPM rate.
The admin.
But I think, yeah, off the admin rates. I think that's increased. Yeah, I know it has increased. I don't know what that increase is. Plus, we can help with Sharon's, having one carrier. UMR can do the eligibility piece, sending that over onto the UHC side, and we can submit that where she has just one place to go for the billing.
And that answers her COBRA question. UMR is
Yes.
already doing the COBRA for medical and dental. I don't know why y'all are paying Deadly Yates to do vision. That is a mystery to
Taking
me.
after 15 or 16 hours.
Yeah, but UMR would just pick up all of that.
Okay. These guys really don't know what we're talking
Talking about.
about here. Other than,
Okay.
we're trying to find some ways to eliminate some administrative tasks that Sharon has that are really quite time-consuming.
And it's just one deduction on your check. Will it just be one deduction or will it be itemized still?
It would, I think it would be.
It'd still be out
Yeah,
still.
and it's
I'm
just
talking
one
about
process for you instead of four.
Well, no, two. She's got,
Well, three would be.
right, UMR and Guardian is what she's doing now. But this would eliminate the Guardian. I mean, and I apologize, I should have thought of this sooner because I'm trying to do this with all of my UHC stuff.
You all got some
No, there is nothing similar to myself.
No.
Okay. How long would it take to find that out?
Well, you want your renewal in September. I could bring everything to you in September, if that's okay.
Well, do we need to know the rates before then, or we all just make a decision to accept it and go, yes, it's a savings, or it's the same, or it's a slight increase?
Yeah, she could get the vision, basic life, and fall life rates, and we could compare that to Guardian now. We could compare that in August, and then you could decide, what
Okay.
you do on that.
Absolutely.
I honestly think that's a no-brainer, because I've really never
I do
had.
too. Oh, that's good.
I've never had it where United Healthcare has been able to match the rates, if not be less than the rates.
Okay. All right.
But that answers, that takes a couple of the questions away, actually.
Okay. You have a copy of this in front
I
of
do.
you? I just highlighted mine.
Yep.
Discussion of UMR nurse contacting our employees and not responding. That was a situation where a UMR nurse is trying to call an employee under certain medical situations. Not for everybody, but if they have an illness that needs follow-up by a nurse and we're having a hard time getting the employee to answer their phone and the nurse is not able to talk to them.
Yeah, that was as a result of looking at the plan performance report, and
There were a handful of people,
I
but
think it wasn't many.
after we talked, basically, UMR is gonna try to make 3 phone calls, and let's just let them do that.
I agree.
Yeah,
That gets sticky.
yeah, because honestly, you can't force somebody to be in case management, you can only ask them.
Right.
And that's something she doesn't need to be involved in.
No,
Okay.
They'll take out any more information.
Yeah.
exactly. Well, yeah, they will, absolutely. I've heard that.
Again, these are, Sharon was not at our last meeting. She listened to it and she just had some comments after the stuff we talked about at our last update meeting a few weeks ago. We were talking about out-of-network providers being used, and Sharon says she always tells the employee, ask your medical provider, don't say, do you take my insurance, just say, are you in my network? There's a big difference.
I think some young employees, I made them learn it in the book.
That's fine.
So that kind of coincided to my recommendation, and I still recommend it, because it can save the plan some additional money. And looking at the last report I brought, you have about, I would say, about $108,000 that were out-of-network claims. And by looking and using the benchmark program, this is where we're targeting those providers that don't want to contract. And so right now, they're under these other networks like MultiPlan or First Health, and their discounts are nowhere near the United Healthcare discounts, but they're taking that and they're happy with it, knowing that they can charge whatever they want anyways. And they're hoping that your plan will pay the difference. And your plan doesn't, because we've got stopgaps in there, but With moving to the benchmark program, you would get rid of those silent networks altogether. There would be one vendor called MultiPlan that would contact that provider who's out of network and say, we'll offer you X percent of Medicare, take it or leave it. And if they say no, they'll come back with another offer. They come back with 2 offers. If they say no the second time, we turn it over to an internal vendor within United Healthcare's company that says, this is what we're offering you, that's it. So most of the claims that can be run through MultiPlan are averaging a 55% discount of their offering, percent of Medicare. Where your members get impacted is they could be balance billed. The difference of what was paid by the plan on the percent of Medicare that was offered and accepted. So if my bill was $10,000 and they accepted 200% of a Medicare payment, the difference could be, I don't know. I'd have to, and I can provide a specific claims example, and I can provide you, I'm waiting on a report of your total claims to tell you what the actual percentage of savings will be. And I can provide a claims example. That's where the advocate would be in place, so that if a member got balance billed, they can call that 800 number. That advocate's going to call the provider on their behalf and try and discuss and work out either waiving that balance bill amount or reducing that balance bill amount.
But remember, you were at a 97% in-network utilization, so this is not going to come up very much.
No,
There is a 3% chance that you will be billed out of network. And I just don't, if I look at it, if you go to the hospital, you shouldn't have to worry about that. If something is wrong, you shouldn't have to worry about it.
That's another question. If you request, stay only on my network.
Doesn't matter.
I didn't know if there was.
We've had a situation with not your group, another group, where somebody was in the hospital here and they were seen by an out-of-network provider. Actually, they were seen by this is crazy, they were seen by an in-network provider, but they didn't file the claim on a timely basis. So United Healthcare did not pay the claim because it wasn't sent in on a timely basis. So then that provider changed to another provider in their organization that was not in-network, because they thought that if they filed it as an out-of-network provider, they could balance bill like what she's talking about. And luckily, the UHC claims rep caught it and called them and said, no, you've already filed this claim as an in-network provider. You can't change it as out-of-network and try to bill this member. That is fraud. That is insurance fraud.
Right, well, like I said, it's...
But to answer your question, no. Even if you've done everything right and you're in the hospital and you've made sure you still have the chance to see, somebody could walk in that room that is not in network and they can send you a bill.
That's not right.
But that doesn't have anything to do with us.
I know,
or you.
that's right.
The hospital.
Well,
The
I think
concept
they need to
is-
comply with the insurance, if you ask me. They just shouldn't let people run over people like that.
I know. You're
Well,
absolutely
and
right.
the legislature just did pass a bill about the standalone emergency rooms, basically addressing some of that, where they can't, advertise that they. Okay.
So, thank you. That brings up a great point, what Tony said. So Senate Bill 1264 was just signed by our governor about the balance billing on the emergency rooms. Because your plan is non-ERISA, you may be able to partake in that new concept. I don't have all the details yet. Our legal team is trying to interpret what that law
It
means.
just was passed 2 weeks ago.
Yeah, he just signed it. And initially, at first glance, it was affecting only fully insured business, but we have determined that non-ERISA plans could benefit from this bill as well. So I will hope to have more information in the next, 30 days most, because I've got a lot of customers asking me about it.
What was the ERISA? I can't even remember what that was.
Yeah, so ERISA is basically, it's a protection for the members, isn't it?
Yeah, unless you're a government, a church, or what's the third thing? if you're a government entity, a church, or I don't know what the others are. Is it just governments and churches?
And that's my two clients that I have.
You're not subject to ERISA.
ERISA.
But it's the employees, what does ERISA stand for? Something,
Rights, I don't know the acronym right off the
20
top
years
of my
ago?
head. Yeah, it's been something that came out a long time ago. But governments and churches do not have to comply with ERISA.
but that could help you. If
Employee Retirement Income Security Act of 74.
that, yeah.
74.
So, but if that's the case, and if you're gonna be exempt, that would help with some of this, because it would,
Like I said, it shouldn't be a hidden cost.
yeah, oh, I
And-
agree.
and-
And tell your legislatures that, because I mean, they need to extend
Right.
it beyond the emergency rooms and the
Yes.
standalone centers, because that's what where they addressed it.
Which is a good start because, hospitality ER, remember I was here talking about them? So, 4th of July 4th, I drove from Hot Springs, Arkansas to College Station, went all the way through all the East Texas towns. And I got just outside of Tyler and all the way through there was billboards on both sides of the roads of that huge facility. And I mean, it's just ridiculous what they're charging, and they're not in network. It's just absolutely horrible as to what they're doing. I mean, I'll give you more data around the benchmark program and then let you make that decision. I apologize I didn't come with that data today, just didn't have all of it put together. So I will
wasn't
have
planning on
that.
discussing it today. Let me just look through Sharon's notes. Sharon, do you have a copy of your notes?
Yeah. I do have a question on the part that the county puts in for the medical and dental. Are we staying at $1,000 for the medical and 25 for dental? The contribution that the county makes per employee that we put over to that insurance.
I'll have to ask y'all that. Is that adequate? Is it too much? Is it too little? I don't
First,
know.
they make that determination.
Yeah, I don't know the answer. I don't know if it's proving to be adequate. I imagine that it is. I don't think that's one of those that fluctuates a whole lot.
Okay.
Okay. Okay, if a new employee is hired and they've had a wellness checkup that we require, may they then just bring me a copy of the EOB showing blood work done? I did allow that the last 2 years. No, we want them to take the specific form to their physician to complete and return.
Which
to
we're gonna get you
UMR.
copies, what copies
Yeah.
for.
Okay, in the past, for anyone whose insurance was not effective until October 1, who is that?
People that would have started like in juvenile, always post juvenile stuff. People that started later in the year, that their insurance won't be effective to October. Most of them probably could call ahead and get an appointment scheduled, but I was getting that someone was like, I can't get in before the end of the year.
Yeah.
Well, maybe they should have called when they first got hired, but go ahead and get something scheduled, but.
And typically, you do give people some leeway that are
Yeah.
hired later in the year, and you don't make them subject to the wellness until January 1.
I think that's reasonable.
For the next year.
Yeah.
I think that's reasonable. We discussed mandatory mail for maintenance drugs. What benefits in hand? Do we need to talk about benefits in hand?
That's kind of a.
Yeah,
It's been in our office.
and what I said in response to your email, I had agreed to pay for the annual fee to have the whole system. The benefit of the system is to make your enrollment process more streamlined. Whereas you send out an email and the employee responds and gives you all the data, then unless you have also decided to use an EDI connection, which would send all that information direct to United Healthcare or UMR, there is a requirement for you to take that data and then go on to the United Healthcare website. And if we move the other carriers, it would just be one carrier to go to. The other caveat to that was ACA compliance. If you have kept up with benefits in hand the way it should have been for the whole year, there is an additional $500 fee, which again, because of the confusion last year, I paid that as well. And y'all could utilize the system to actually send out your forms to your employees that are required by ACA under IRS, as well as the electronic fee that would have gone straight to the IRS. So honestly, but if the system's not being utilized like that, and if it hadn't been touched since April, it will have to be updated in order to be in compliance and to get all your ads and terms back. And Jessica's already done that twice. So I'm just gonna say, if y'all are not gonna utilize the system, let's just turn it off. I mean, it's y'all's choice.
Yeah, we need to talk to Carl before we.
I mean, I will continue.
This needs to be a you and Carl and Barbara decision. We don't know.
It's because you're having to enter that data.
Yeah.
And EMR and.
Well, if you just had, if you had MASA United Healthcare, MASA doesn't have an EDI fee. United Healthcare, what the charge is to have a direct EDI feed is $250 a year. That meant if you were utilizing benefits in hand and you plugged it in there, it would automatically send the EDI feed directly to UMR United Healthcare. And if you do what I suggest to do about making UMR United Healthcare be the carrier for the medical, the dental, the vision, the life, everything would go. But the caveat to all of this is, if you've not used it since, it would have to be updated because nothing's been entered in it. So it'd have to, basically, Jessica would have to go and do all of that again. And we're entering into fourth quarter, which is a really busy time.
That's what I was just going to let you know is our EDI cutoff is September 12th.
Okay.
Okay, I think.
EDIs.
Not the children's.
Because I'm not part of the 1095 production. Last year, like, we were grasping and trying to get it. I know Jessica came in and helped. There were all of those. And then we ended up having to pay a company $500 and something to either do the mail out.
They charge $3.50 to mail and to file with IRS for every employee that you have provided, even for 1 day of coverage. It's everybody. And, in the past, Christy pretty much did all of it manually. And we were just trying to give you a way that.
ACA is the benefit.
Yes.
But we're duplicate insurance.
Well, but everybody's got duplicate entry unless you do EDI feeds. So EDI feeds is the way to get around that, but the EDI feeds, according to Chris, would have to be implemented by September the 12th. So, I mean, we don't want to force y'all to do anything you don't want to do. I was thinking this would be a help and a benefit to you. If it's not a help and a benefit, let's not do it.
Well, I think one of the issues, if I may add, is the fact that, well, when I came in, I've never had to prepare 1095s. Everywhere I've ever worked, they've always been done by a provider. So when I came into the office, I was told that it was all going to be worked out, that Higginbotham was going to take care of the 1095 piece. And so that's just what I was told when I took my role. And then Sharon, because she had already been here and was already into it, it was kind of her first year, she picked it up and did it because she's the one that knows the insurance side of it. So I think Christy figured out a way how to do it in that data and to get the information. Am I correct?
No, Christy never had the data.
So
She ran her stuff, but she did it manually.
Christy ran it with UMR's reports because we didn't have benefits in hand when Christy was here. But what we're talking about to guys that don't understand it, any employer group that has more than 50 employees has got to provide filing to IRS and to provide that same form to every employee so that they can submit it onto their individual tax return. And most companies charge $4,000 or $5,000 to do this. But because benefits in hand had the capability, that we thought that would be a benefit to them. If it's not, as I said, if it's not a benefit to you, then we'll just scratch it and y'all can, because the employers, it's the employer's responsibility. The only time a carrier provides is when you've got a small group. Those are sent directly. Any group under 50 people, the 1095 form is sent by the carrier to the IRS and to the person. But groups that are over 50, the employer is responsible for those forms, not the carrier.
No, what I was saying was we work with UMR, we did use benefit in hand where I worked before, that's how we did it. But they did it all in the background, we didn't do it. I did W-2s and 1090, but we didn't do the 1099 because it was all done in their contractual. And I think benefits in hand is basically how I went in and signed up for my benefits. So I understand the layers of what you're saying, but here in the county, when I came in, this is I wasn't a part of setting up those pieces. So I inherited those pieces, and I think going into October, we're gonna have a changeover of the auditor, we've had a changeover of the first assistant. I know Christy sat down and manually did everything out of pure frustration and just said, this is what I can do, I'm gonna come in here and do it. And then when I came in, it was this system's supposed to work, and everything was supposed to work, and I think Jessica was very helpful in coming in and getting the data, because that's the first time. So why are we not utilizing benefits in hand if it's going to do all these pieces for us? That's what I don't understand.
You're asking me?
I'm asking either because you're our consultant and I don't do this.
Well, we set it up for you, so all we can do is give it to you. We can't do anything else more than that.
Well, Sharon, what should we do?
What is the piece of it that's missing?
Sending somebody up and sign them up there that doesn't have everything they need when they come in the first time to sign up. Requires a second trip back in. And then when they do get done, I gotta go to, Herside, Guardian, and Monza, Colonial, 4 different places and re-enroll almost.
Most employers send a link to the employee through an email, personal email, work email, whatever it is, and that person enrolls.
And some give it to me and some don't give me emails. Now, if they let them do it over the work email, that might be different. Not everybody uses an email.
But once the employee is given that link, they go in and they enroll themselves in benefits in hand, and they make their open enrollment elections, and then an email is sent back to the auditor's office, says, here is what I want to enroll in.
Because right now, an individual walks in the door and sits down. We go over the benefit book and everything else, and they fill out the paperwork.
One by one, Sharon, one employee at a time, so you have to do it 143 times.
Well, maybe 20 in a year, something like that.
Well, she's talking on the new hire.
Yeah, just a new one.
Oh, that's what I'm talking on. Once they're set up in there, they
But
should
for
be
open
in
enrollment,
right?
the way we like, for groups that have benefits in hand on open enrollment, we really, it's very seamless. We open it up for like a 10-day period, and we send out another link and say, it's open enrollment time. Go on to this website and choose your new plans, whatever it may be. And then those all go, again, are accumulated and go back to, but again, usually Jessica does your open enrollment elections. Those aren't, Sharon didn't do those, Jessica does those. So really, the only elections that have to be done are those that come through the year that are new hires. But if the plan's not being utilized, it's not going to be effective. If the system's not being utilized, it's not going to capture.
Well, it's cheaper to pay for an EMG everywhere.
Yeah.
And have to go for one source and try to figure out how to do this 1095s at the end of the year.
Well,
I personally use benefits in hand, now that you explain it to me, Tony, because that's what we use.
Okay.
I got an email, I went in, I input my stuff.
We're lost.
And it's gonna be our office discussion.
Okay.
Timeline
But
right now, I turn over this to the.
You just need to tell us what it's gonna cost us or what it's gonna say.
You would still have that
ACA
ACA,
before we get into December.
you would still have this, because again, so fees, let's.
Okay, Tony, y'all are talking to us like we know what you're talking about.
Okay, so let me stop at that. To have the online enrollment tool, the benefits in hand software, it's a $500 per year fee. I have agreed to pay that, and I will continue.
Even going forward, not just that first year.
Every year, and I've agreed to pay it every year.
Okay.
Okay? To have ACA administration done, where they're going in and summarizing all your data, putting it all in, because Benefits in Hand actually sends it to a third-party administrator to create the forms that go to IRS and the letters that are mailed to each employee, because it has to be right now, it has to be a paper mailing. That is the $350 you paid for the additional cost. Yes. But that's $500 to have the ACA tool, and then whatever the $350 cost is still cheaper than going and having a party that will do your ACA compliance. Okay? The third caveat to that is EDI fees. So every carrier, the Higginbotham fee is $250 per feed. So if you're on United Healthcare for everything and you get away with Guardian, and Massa doesn't have a fee, that's $250 to do the medical, the dental, the vision, the life, the ball life, all of those carriers, all those lines. You would still have to, Massa is not feedable, and I don't know anything about Colonial. Okay? So I'm just making sure that y'all understand the fees that I'm gonna pay for and the fees that y'all would, but still, like, saying $250 a year is nothing for an EDI fee. But Chris is saying that has to happen by September the 12th.
To get it done for 1/1.
We would have to have the EDI set up.
Set.
Everybody.
We also will have to have new hire employees.
Everybody.
On that computer that's in there.
And you're gonna have to catch all the stuff that you missed.
Today.
Because that's the key point that I'm missing, because even the county I came from, everything we entered into the system entered into the interface. That then transmitted out, whatever needed to go to the insurance company, whatever needed to go in for ACH reporting. So you're saying if we set them up, Sharon wouldn't have to put them in the MRP.
Correct.
Already feeding.
Correct.
And it was a $250 fix.
Correct.
It was addressed this 6 months ago.
Correct.
Yeah. That's what you told me at the time, was that you got. Okay. And I communicated that that's another Carl piece.
Yes, it's
Yeah.
gonna be a lot.
Yeah, making that decision and getting that set up.
Our issue with this is that I just started EDI implementation for about a 250-man group. And Benefits in Hand and UHC is telling me 6 weeks,
Yeah.
starting
You can't
2
take-
weeks ago. Because you're not gonna have your data.
How did we do that last year?
What?
How did we get it
That's
today?
good call, so.
Jessica went back and had to look at all the data, and that's twice as hard for her, because she didn't know you're coming to go. Jessica's my account manager.
Yeah, I know she helped.
Yeah, I was just saying, yeah, what am I, yeah, she's my person. So Jessica had to go back and gather everybody that had terminated, that had hired.
What if we
and-
scrub the data and provide it?
That's what's right.
I can have the data if I can get in.
Okay. What else do we need to do? Y'all can sit here till
I
this
guess y'all
afternoon.
need to decide if you're willing to pay for it, if you want to do that.
I think it needs to be.
I think that the auditor's department, along with Carl, needs to talk about the pros and the cons and decide what they want to do and just make a recommendation to
Why
us.
don't we just set a meeting up together, just us?
I think the court will be very receptive of anything that relieves time-consuming processes.
It helps.
Okay. Well, we'll get together and we will visit, and then we'll let y'all know, and then if that's something, I think the court needs to vote on how you go about, approving this going forward, and then we'll break out those different layers and let y'all see exactly.
Yeah. Well, if we don't understand what you're talking about, it's going to be hard to vote. If we do, and we just don't
Well, I mean,
deal with
it's
this.
$500 a month to do ACA administration. That's what I'm talking about, you have to vote on. The court is going to say, I'm going to agree to let benefits in hand / Higginbotham handle ACA administration. It costs $500 a month. In addition to that, we know that there's a $350. No, a year. I'm sorry.
I wrote down
A year.
here.
And then the $250 EIP. But if we're doing that EIP, folks, we need to start that yesterday.
That's what I'm saying. That's
Yeah.
what I'm hearing.
Okay. Time frame going forward, when are we going to plan on trying to do open enrollment?
I suggested the October 3rd, 4th, or 10th, or 11th. When the holidays fall, like for
I could do 10th and 11th.
If we do it the 10th and 11th, if you do it, I'll be there. If we do it the 10th and 11th.
Well, we've got trial, we've got court in here on Thursday because of our district attorney handling things for our county attorney. We're having a full day of court on Thursday the 10th.
What about 8th and 9th?
That's okay if you will have all the information you need to read about the court. I can't do it on the 10th. I usually it's 6.
When is court, the 10th?
No, the 9th, or, no, the 10th, yeah.
It's going to be on the 11th of October. Because it's on Wednesday.
I'm talking about criminal court, where this room is across the road, where,
In one of the courtrooms, we use one of those for open.
What about the next week, Sharon? Is that too late? Which one?
well, that's fine, yeah, but everybody's used to coming up here. We can use the conference room there in the,
We'll probably do the 17th and 18th.
I can do the 17th and 18th.
That would be the longest.
Or the 15th, 16th?
I would be Titus the week before that with payroll. And
What information do we provide?
they get a lot from their own.
Okay, and here's the thought process too, and I know y'all don't know what I'm talking about. but I think it's all- If we can get benefits in hand, up and running, and workable, then why would we use that program?
I would set it in wrong in person.
Open enrollment, no, we send them that email link and they do everything. We got like a 2-week period that they go online and they.
Normally, don't you have one?
Normally-
Workstations where people can come in there.
No,
like,
we just come in and she goes over everything verbally.
Well, open enrollment has typically been paper. So, and then it, like last year, just have to take the paper and enter it in to benefits in hand for the ACA, and then enter it into the carriers to get it updated as far as the coverages go. But what I'm saying is that if, and I really wish you were here to tell me about it, it's not. But, if your benefits in hand was workable, then I say, you say 2 weeks in October, you might have we would have group meetings, go over the coverages, and then say, you've gotten a link on your whatever, everybody, in this day and age, surely everybody has an email address. Are there
I
people
don't get
that?
them from some people. Some people tell me.
no, not necessarily.
Some of them still have flip phones.
If you don't have that, then you come to the auditor's office.
You used to know someone that did here.
And then somebody there would would just plug in his benefits in hand. The other thing that we can do as well is that if I've got enough leeway, Higginbotham has got an employee response center where people could call in and just tell them their elections over the phone.
That's it, right there.
And that way, they could do it, it is Monday through Friday at 8 to 5, but somebody could just call in and say, okay, I've got my bill here, I want to do the dental employee only, I want to do the vision employee spouse. Yes, and then that, and because you're on benefits in hand, the ERC people people just pull up that person's information in the system, and they're just doing it while they're talking. I think for all of this, we need to get together and have a meeting and decide what to do before anything is in stone. You know, we just need to, but my point is that you have to decide how you're enrolling. You're gonna do paper, you're gonna do online, where it's just feeding into this. So what day next week did y'all maybe get, does Carl need to be involved in this? Okay, so what day, is he gone next week? You're gone next week.
But you don't have to have any papers, obviously.
I could do Wednesday after, anytime Wednesday. And this is really Sharon's area.
I tell you what we're gonna do, we're gonna close this meeting
Okay.
here and adjourn, where we're gonna, at least we finish with the discussion, we're gonna go to item number 2, and that's consider and possibly approve any changes. The only change that, again, we talked about that I would be in favor of would be mandatory maintenance drugs with Optum RX after 2 refills. I'm not going to make that motion as the chair. If anybody else wants to make that motion, please do. Otherwise, any other changes you've got, if you have no other changes you want to consider for this plan, then I'll entertain a motion to adjourn.
Do y'all need to vote on any Carolyn PHI access?
No.
Make a motion, we adjourn.
Okay, motion is made by Commissioner Fitch to adjourn at 12 o'clock.
Second.
All in favor, say aye.
Aye.